recording. If we're recording, I'm just going to jump in and start. This is a short presentation I wanted to do on setting up a tox clinic for medication-assisted treatment, or really more formally now, medications to treat opioid use disorder. It's a pretty significant component to the tox clinic that we run here at the U of R. No disclosures related to this. Some learning objectives for today are to describe the transition, how to transition the standard toxicology clinic to support treating patients with opioid use disorder and other substance use disorders. I'll talk a little bit about billing and implementing the appropriate infrastructure for this to occur, because obviously you need to get some reimbursement or grant support or something to support your time to run the tox clinic or see patients in the tox clinic. We'll talk about the most common billing opportunities in the clinic setting, and then we'll have some time at the end for Q&A, and not just for me, but for the administrative support as well. Stephanie will be available. She's here presenting. A little background first. In 2011, we opened the tox clinic. This is the year that we started toxicology consults in addition to the Poison Center coverage at the U of R. The Poison Center had closed, and we transitioned really into a single provider coverage, consult service, seeing patients Monday through Friday. And the clinic opened one half day to start with a month, using the occupational medicine clinic that we have on site here as the actual clinic site. I'll talk a little bit more about that in terms of what was needed in particular for opioid use disorder. But in general, the first clinic patients were standard toxicology cases. We had a 10-page intake form, and we still see some standard toxicology cases. Mercury exposure, I looked back at some of the early cases, and we had a gentleman who was exposed to ciguatoxin. There's certainly several no underlying toxicologic significance cases, and lead levels, some HIP, chromium, cobalt interpretations. In 2012, I began working at an outpatient chemical dependency treatment program separate from the academic appointments, covering primarily patients with opioid use disorder, providing medications to treat opioid use disorder, usually buprenorphine, occasionally naltrexone or extended release naltrexone and Vivitrol, sometimes other patients, but by far the greatest number of patients were with buprenorphine. But before setting up the clinic to see patients in the hospital, to bill successfully, to be able to generate any revenues, you need a license, you need to be credentialed. You need to be credentialed with insurance providers in the area, and you want your billing and coding supports to make sure that they're credentialed with the common insurances in your area in order to see patients both in the inpatient setting as well as the outpatient setting. There is a separate tax ID now for medical toxicology, a specialty ID for medical toxicology, a specialty code. We'll talk about that. And to see patients for medical toxicology, if you have a primary appointment in emergency medicine or internal medicine, you'll have a tax ID that you're billing, whether it's under yourself or under the faculty practice for that department. You'll need a separate tax ID for medical toxicology. And I've got a link here if you're interested on how to obtain it. It's actually a fairly simple process. You have to have a separate ID to bill under a separate specialty. You can bill under the separate specialty when you're billing under your primary specialty. I'll talk a little bit about that. The tax ID is what separates you from your primary specialty. It has its own budget. Then you need your own budget and ledger under the separate tax ID to be separate from emergency medicine. Most medical toxicologists are emergency medicine or internal medicine if you're doing that at the hospital or clinic as well. The specialty code, the MedTox specialty code, is useful, but does not obviate the need for a separate tax ID. A little bit about the specialty code. On October 1st, 2017, medical toxicology was recognized. This was established by the Center for Medicare and Medicaid Services and identifies MedTox as a separate specialty. This will help simplify processing and billing concerns, less denials potentially, and allow for systematic review of toxicology billing and supports as distinct from other medical specialties, and potentially some other benefits as well. But that hasn't been comprehensively looked at. Dr. Lycan had looked at how the specialty code impacted his practice and has presented on that. We've not done that here at the U of R. One of the things we're looking at in the future. So CPT codes, there's a variety of different CPT codes that you will use depending on where you see patients, whether it's in the inpatient, ED, ICU, OBS unit, or clinic. We reviewed the different types of CPT codes that were used by toxicology at the U of R, and this is a list of all of the CPT codes that we used from 2011 to 2014. Didn't have the data after 2014, but in general, they would be very similar. The clinic codes are going to be a very small number of these. They're going to be the 99201 to 05, the 99211 to 15, and then some what I call adjunctive codes, the audit DAST, which is a counseling code, the oral medication administration, potentially. Actually, we use that more in the inpatient setting. That's when the provider would administer medication or do a buprenorphine induction with the patient. You may be doing this in your clinic. We don't do a lot of inductions in the tox clinic here. And then smoking cessation, the 99406, 407. A little bit more about these later in the presentation, but there are a lot of different codes. The vast majority, the most common ones that we use are going to be the bedside consults in the ED in the hospital setting, and those are the 99221, 22s, 41s through 45s, 51s or 55s, and then the crosswalk ones, the 22s, and then the subsequent visits, the 99231 through 33. This is a slide that shows the breakdown of insurance coverage and the charges, and also what's allowed. The allowed is the reimbursement type. So you, in order to, if you're putting together a business plan, you need to know the breakdown of the insurances in your area, and then what type of CPT codes you're going to use. In the clinic, you'd use the ones I mentioned in the previous slide, and then what you're going to be charging, and also what's allowed by insurance, because what you charge is not going to be necessarily what you get. So you can see, the average breakdown in the clinic. It's pretty common to use a 99203 or 04, probably a level 4, which is a 25-minute visit. So if I have an Excellus patient, I can bill $470 for that encounter. We'll get reimbursed $181.13. That's a new patient initial visit encounter, so that fairly well reimbursed. That's going to be about a 40-minute, 40-minute encounter, I believe. The subsequent visits, the established patients, the one we're seeing month after month or every other month, are going to be the 1-3 and 1-4. So if I had an Excellus patient I'm seeing every other month for 25 minutes, we'll be charging $305 for that visit and getting reimbursed about $110. This is an older charges and allowances, and the only ones I had access to. So it's a little bit different, a little bit better in terms of the allowed, but I think it's fairly close, what I've looked at our records, to these rates. They're going to vary. It's important to know other mediums of value, the relative value units. If you're in an institution that's supporting mostly uninsured, you're not going to be collecting a lot of revenue, but you should know what then relative value units for each encounter are, and this is a breakdown of charges and RVUs by encounters that we've had. This is from July 2016. You can see the different RVUs by encounter type, and I don't have a separate slide that breaks down RVUs by common CPT code, but those are available. I've sent them out previously. I can resend that out again if there's any interest in having that accessible. The insurance mix in Rochester, New York is better than a lot of places around the country. It's not as good as some, certainly. The mix of managed Medicaid and Medicaid, self-pay, Medicare, and private insurance is pretty good. We have a lot of Blue Choice, Blue Shield. Medicaid is about 20% of the inpatient encounters, and about managed Medicaid is a higher number of the outpatient encounters, because most of the patients are coming from graduating from an area treatment program. So it depends on where your patients are coming from, if they have private insurance or Medicaid. But that's important to know, obviously, if you're putting together a business plan in terms of revenue expectations. We had gotten a report in general that would break down the charges, the revenue, the types of encounters. looking to get this again when we had a turnover, and this is an old report, but it basically breaks down the number of encounters by month. When the clinic first started, we were doing very few clinic visits. Now the average number is about 35 to 40. We have a number of patients that are on bi-monthly as well. And you get a report. It's important to get a report. If you don't get one, you should ask for it so you can understand where opportunities are, where deficits are, your productivity, and this would be something generated by the billing and your department or division administrative support can help you potentially with this. Your practice manager should be able to help you with that. Buprenorphine visits in the clinic are not one size fits all, and it's important to understand that just like buprenorphine visits in the hospital are very diverse. I've got a slide that describes common buprenorphine-related or opioid use disorder encounters that we see on the toxicology, or now the toxicology addiction consult service. We start buprenorphine in the ED, and then the hospital are often called to continue it when there's questions around dosing, which is usually when there's pain or need for perioperative management, trauma. Illicit buprenorphine that the patient reports coming in will often start or continue regular buprenorphine. Transitions to and from methadone potentially, or naltrexone. In addition to the buprenorphine consults, we also do some alcohol use disorder management, starting naltrexone and appropriate pharmacotherapies. And I only mention that in this context because the clinic, the tox clinic, is also an appropriate place to follow up treatment of alcohol use disorder, not withdrawal management per se, but naltrexone, acamprosate, things like that. And we've started doing that in the hospital setting as well for appropriate patients. The encounters in the clinic, there's a variety of different models you can have. We have a model of more of a long-term maintenance clinic, and also supporting appropriate patients from the hospital that don't have follow-up. Most of our patients have graduated from an outpatient chemical dependency program. Some colleagues that I have in the area run a bridge clinic. Their toxicology clinic is out of the ED or associated with the ED. Patients that are identified as having opioid use disorder and don't have a rapid access into a provider, whether it's primary care or outpatient treatment program. The tox clinic can serve as a bridge clinic, and Ross Sullivan in Syracuse runs one. The team in Cooper, Rachel Rose, and some of her colleagues, I think, run a bridge clinic. There's several others that have different models of this as well. And we've had patients from the hospital as well that we couldn't link to outpatient treatment programs, some trauma that came in on buprenorphine, no other illicit meds, and just didn't have a provider that we could continue bridging them to from the hospital, so followed them in the clinic. But there's a lot of other opportunities if you think beyond just simply starting and maintaining buprenorphine. The more complex patients, especially around painful procedures or perioperative management, the primary care physicians often get uncomfortable, or even the providers that have been doing buprenorphine for a while. So as you get comfortable dosing buprenorphine for pain and in the mix with other medications, other opioids even, you potentially could use the toxicology clinic to support more complex patients. And I already mentioned a little bit about other substance use disorders, alcohol use disorder in particular, where you have naltrexone and acamprosate. And we're looking at just beginning to look at the use of Sublocade, which is the long-acting, the monthly depot injection. There will be some other formulations later this year, and the tox clinic may be a good site to support patients related to the depot buprenorphine preparations. There's some logistics around that, but that may be a good model. So we have 3 half-days a month, regularly schedule it on Thursday mornings, run from about 8:30 until noon. We rent or purchase time and support from an occupational med clinic on site. The patients are booked every 20 minutes to a half hour. If double coverage, there's either one boarded tox and addiction faculty on, myself or Nick Naka, and then we have 2 addiction faculty, former EM residents that had done the fellowship here and stayed on, and as part of their position, cover a half clinic day a month. So that usually is double coverage, about 75% of the time, and single coverage 1 out of 4 days. This is also a clinic where a lot of the fellows, residents, and pharmacy students see. We've got the medication reconciliation counseling done by the pharmacy students, have a separate form that they use and that get some experience interviewing patients and counseling on medications, and it's a good experience for them. Administrative support is critical. Stephanie Hagberg, who's here with me, and then will comment a little bit on her role. She arrives the patient. We have an intake nurse who does the vitals, rooms the patient, although really the rooming is more patients sitting in the waiting area until a room opens up, and we have kind of a numbered series in which the patients are taken to the rooms. A urine drug screen is done. We've got a process for that. I'll comment a little bit on in a few slides. The patient summary is about 35 a month. 25% of the patients are on bi-monthly. We've got criteria that if they're over 2 years stable and doing well, then we'll move to bi-monthly. Most are long-term maintenance, graduated from outpatient chemical dependency treatment programs. Several, like I mentioned, were linked from the hospital and continued. Only illicit buprenorphine involved in a trauma. One travels 60 miles once a month to the clinic because there's no providers in the area that could take on the bupe. Some insurance issues in the way that it was prescribed for both pain and dependence that the providers just didn't want to get involved at. We're looking at buy and bill related to Sublocade potentially that hospital has. We may be able to buy under the hospital code, which gives us a lower price, and then administer it, generate revenue from the administration as well as the higher price that the insurance would pay, so that could potentially subsidize some of the clinic space if we can get that set up. Looking at extended release naltrexone, but haven't done that yet. Primarily seeing patients for opioid use disorder, the occasional other toxicology patients, occasional alcohol use disorder, and then most of the patients with opioid use disorder are also being seen for nicotine dependence, which is an adjunct of code. I'll let Stephanie comment a little bit. The administrative and nursing support is critical. We have a clinic line that's available generally Monday through Friday, 9 to 5, leave via message or office. And I've listed some common questions, but Stephanie, if you want to comment a little bit about the administrative supports and how maybe the patients access the clinic and what your role is.
So, like Tim said, a lot of them are calling in for, they needed name brand script instead. So I'll reach out to the pharmacy and Tim as well to make sure. Other than that, it's really just phone calls about rescheduling their appointments. I've had a lot less calls since we went to setting up their follow-up appointments for them. So that's really mainstreamed a lot of the issues that were going on before with phone calls.
Yeah, that's a great comment. We've tried to, and Stephanie's been critical in this, taking where there were variables or, each patient at each encounter, we had to then find when they would follow up next. Prior to the appointment, she'll have the card made out with their appointment scheduled so we know when the follow-up is, and really also track when the buprenorphine prescriptions are, because we have 3 half days a month, so that sometimes that doesn't always work out to 4 weeks. The patient may be needed to schedule 5 weeks out in a shorter week. So logistic stuff that if organized in advance is really simplifies things. Also the formulations, I don't know how many others are doing this, but there's so many formulations out there now for buprenorphine, and some insurances cover one, but not others. Just straight Medicaid only covers brand names. Some patients have dramatic preferences and they have to have the brand name, and it is a crisis if they don't get the brand name. So it's really important to have this tracked and to try and do this right, as you said, in the first prescription, because otherwise there's a lot of calls and a lot of panicked calls, and then time and effort needed to just change the prescription. There's questions about lost insurance, changed insurance, wrong dose, wrong formulation, pharmacy issues, refill of adjunctive medications, and this is just a normal part of the clinic, the tox clinic follow-up when you're starting to see patients more than once or twice for encounters. But in general, very simple. And again, it's critical having some administrative support, also with knowledge and empathy related to the treatment of substance use disorders and addiction. Stephanie's taken some additional training, recovery coach training, and she had created a certificate program for the patients, which they really, really like. They graduated from an outpatient program, but we're tracking how long, they've been in the clinic or doing well, no use of other opioids, and she'll have a certificate ready if it's 1 year, 2 year, 3 year, 4 year, 5 year, and the patients are really excited. This is something I think that goes an awful long way. Had some breakdown into tears, and just very proud. One other pearl is get the patients involved in other recovery activities, peer counseling opportunities, volunteering. I've had some volunteers come to X-waiver trainings that I've participated in for the emergency medicine residents or palliative care department. They wanted a large training, so we were able to get some patients to talk about their experiences, one during pregnancy, one through surgery, how different things that arise for them, how the buprenorphine is working. We've got one of our patients that is taking the lead for peer counseling for an area outpatient and has just done a fantastic job setting up a separate program in the area. And he went from that as kind of a secondary job. He was doing some contracting to that as his only job. He's jumped in, head in, and I think will eventually be headed towards counseling, but it's really neat to see. Drug testing is a part of this. So if you're thinking, what do you need to run the appropriate medication for opioid use disorder clinic, drug testing is going to be part of it. Have a process, educate staff, everything from specimen collection, how is it done, check the temperature. What if the temperature's off or there's some concerns about how it's collected? That we have the nurses just contact me or the other providers directly rather than wait. You need to have a typical panel rather than just order separate things. We usually will get buprenorphine metabolites and then have a standard other panel, which includes opiates, fentanyl, cocaine, benzodiazepines, ethylglucuronide, ethyl sulfate, amphetamines, methamphetamine, THC, methadone. Really test for things that are going to influence your treatment. Often the labs will offer a panel if it's not in-house. We have an in-house lab that just got an order sheet that each time have to sign and send down with the urine sample. And just so it's done as our other standard labs in our institution. But I know a lot of other toxicologists that are doing this outside of a hospital, so they have to contract with some of the independent labs, ACM, Millennium, and have some communication so you know what is done with billing, what if a patient is self-pay, what's the prices, what if the insurance doesn't cover, so there's no big surprises from patients. Patient support, be clear with what you can support from the start. This is a bridge clinic or this is a long-term maintenance clinic. There should be a contract, a policy. If missed appointments, call in. Are you going to call in a prescription? How many times do you do this? Do you have observed dose or call in random policy? What if there's other substance use with buprenorphine? Just be clear from the start so there's no surprises for the patients. Got just a couple minutes on the E&M codes and the CPT codes that you're going to use in the clinic. The new patient codes are the 99201 through 5. The existing are 99211 through 5. There's a little bit of information taken from CMS on what you would need for different level of codes. It's just like the other billing codes that you use. The higher the number, the more complexity or the more time. Most of these encounters that we do in the clinic are time and counseling based, where over 50% of the time needs to be spent counseling. The substance use disorder treatment encounters are very counseling oriented. The new patient codes are the 01 through 05. Patient is only a new patient in the clinic once. So you'd have the first encounter, a new patient, and then the second would be the subsequent. After that, you'd use the subsequent patient encounters. The time-based billing for the new patients, the 01 is 10 to 19 minutes, which is almost never in a new patient encounter. We're usually at 99204 or 05. So if it's the first time they're there, you can have a little more time. We've just got some examples of what is needed for the different levels of CPT code. Most of our established patients are going to be billed at a 1-3 or 1-4, and a 1-3 is a 15-minute encounter with just an expanded problem of focus history. The 1-4 is more detailed and is 25 minutes. The 1-5 is 40 minutes. We do occasionally will have more time that needs to be spent if a lot of issues arise. There are some associated codes, the add-on procedures, and they can be done both inpatient and in the clinic. That's going to be the smoking cessation, additional counseling, although usually we just do, if we spend more time, a higher CPT code. And then the med admin, which would probably most commonly be the buprenorphine induction when you dispense the med. So probably not often in a clinic, more often in the inpatient setting when we do the dispensing and observe the doses and teach a patient about the induction. But very common to have the smoking cessation encounters, and now they're no longer just for smoking cessation. I've got a couple slides on Q&A, and then we started a few minutes late, so I'll go a couple minutes longer and answer some questions. We've got how do I differentiate between the outpatient and inpatient clinic codes? I've covered that. The outpatient are the 99201 through 05 and 11 through 15. There is also an outpatient code that is the ED outpatient seen before admitted to the hospital. That is not a clinic code. That is an outpatient just not admitted to the hospital. That would be the 41 through 45s. What are common reasons there's denials that occur? The note didn't support the level of service, so it's very important to have a template. We have a buprenorphine visit template that includes key parts. The attestation is really important if you have a resident that writes the note or a fellow. The insurance company requests some additional documentation, so responding to the denial is really important. Duplicate services or claims billed, that doesn't happen too often, although if you bill the same level of service, that's more of an inpatient issue. For example, overlap in critical care times. I've got a little bit about the counseling-based codes, adjunctive codes that this presentation will be available, that if you take a look at and have questions, let me know. Smoking cessation is now more than cigarettes, just so vaping, chewing. We used to do counseling related to tobacco chewing. I have several patients that are chew, and we wouldn't get reimbursed. Now, with it's expanded. The counseling can include for chew as well as for vaping, and make sure you have the appropriate attestation if you have a resident see the patient or a fellow. I've got some examples that I've sent out previously, and that's the presentation. I'm gonna ask if Stephanie, you have any other comments or thoughts, or does anybody have any questions for myself or Stephanie? I think we didn't talk a lot about Stephanie's role, but it's really key to have administrative support that is interested in this. She answers the phone and does a lot of other work, but supporting talks in other areas. The clinic support is just one of the roles. She is on site when we have the clinic, which has simplified the encounter process for the patients quite a bit. So we have an encounter set in the computer, but you will essentially room them in the computer system, right?
Yep.
So,
yeah. I would say one thing that's helped a lot is having access to the PMP and matching up when they're running out of their prescriptions to their appointment dates. So that saves a lot of their needing a bridge script or, falling short before their next appointment.
So we've got a couple of questions on the chat that I'm going to get to first. We've got from Michael Cherry. How did you arrange for the space for the clinic? So that was initially arranged as a agreement between the practice or program support or practice director, basically, was able to coordinate with occupational medicine years ago that they had some clinic space available. It's pretty common in the hospital, in medicine or pediatrics clinic may have support for patients, but only see patients half day because faculty are only available or residents only available half day, and they have the nurses and other support there. Our occupational medicine had a clinic at a light day on the Thursdays, and so initially we were able to rent basically the clinic, 1-2 rooms, as well as some services from the nursing support there, which was the collection of the urine drug test, and then vitals and rooming, and very simple in terms of the vitals and rooming process, but that was rolled into the cost of the clinic. I don't have the costs in this lecture, but I could, in general, let someone interested know what we're paying for 3.5 days a month. And then the second question is, what are the costs with using an EMR? That's a good question. There are different EMRs available. If you're doing this privately, I don't have to pay separately for the EMR. We use the hospital system EMR, which is Epic, which is a really nice electronic health record. But if you're doing this yourself and setting up a private clinic, then you're going to have to look at records. I have some colleagues. I know Derek Eisner was looking at separate medical records, and maybe we can find some information from those of you that had to set this up separately. Now let me see attendees. So if there's other questions, we've already gone over the time. We've got to jump into the case conference. If there's other questions, we're available offline, and I'd like to do this again and have some other presenters. I know that Joanne Lace has a group in Minneapolis that may be able to present as well. So we'd like to do different models of not just clinic support and treatment of opioid use disorder, but also for the inpatient and practice-based presentations. So we're going to end the presentation. I want to thank Stephanie, and thank you all for attending. I know this was somewhat last minute, but wanted to get this recorded and then continue to do this in the future. Have a good weekend. Hopefully you join us for the case conference, which is a separate login. Thank you.